Thank you very much. I will try to start my slides using the technical system. In the meantime, I am very pleased that we can meet in this way, even though, of course, it would be even much nicer if we could meet in Santiago or in Amsterdam. And I bring you greetings from Amsterdam, which you can see on the first slide. And I would like somebody to confirm that you are seeing the slides now.
Yes, we are seeing perfectly, Dr.
And they are moving? Are the slides moving? Oh, excellent. Okay, thank you very much. So I wanted to show you my city, Amsterdam, and this is on a beautiful day. Today is not so nice. There's a little bit of clouds, but still it's the first real day of spring. And of course, I realize that you are in Chile, where I think you've had the summer and it's already the fall. But in Amsterdam, we had the winter, and now we are looking forward to the spring weather and the summer. And here in Amsterdam, we are a large university medical center called the Amsterdam UMC, which is a merger of the VUMC and the AMC. And those were two different university medical centers until a few years ago. And you may still know the names. And we also work closely together with the rheumatology group at Reumatoide, a large practice with many thousands of patients who are also very research minded. And we work together in the Amsterdam Rheumatology Center. So I'm very happy to be able to talk to you today across long distance about rheumatoid arthritis. And to talk about rheumatoid arthritis, I always like to look back a little bit to the past. This is, of course, rheumatoid arthritis, the way we have learned about it, the pain and the loss of function being the hallmark features of this chronic disease. And in the past, things were perhaps not so good for the patient with rheumatoid arthritis. And I like to start a long time ago in the 19th century with the French painter who made this beautiful painting. His name was Pierre-Auguste Renoir, and he had a beautiful style in the Impressionist time with happy people sitting and enjoying the lunch in the sunshine and happiness everywhere. And his life was also happy until at a relatively advanced age, he was also struck by rheumatoid arthritis. And his case was very well documented. It was possible to see the changes from the rheumatoid arthritis on some of the photographs. The picture on the left, the hands, is not an original photograph, but the picture on the right side, that is actually Cézanne sitting there. Sorry, this is of course Renoir sitting there, and his hands are very severely deformed due to rheumatoid arthritis. And it was witnessed that his friends had to tape the pencils to his hand so he could keep on painting, even though he had very severe arthritis. And certainly the last part of his life was marked by this severe disease, for which at the time there was very little intervention. Perhaps the only intervention that was possible in his day was aspirin or acetylic salicylic acid, which at high dosages can give some relief. And also, interestingly, he may have been one of the first individuals who received a new way of helping patients with a handicap, the wheelchair. It's very well documented that he used a wheelchair at the end of his life, and that was actually a new invention at the time. Now, interestingly, the acetyl salicylic acid that I mentioned was, in other words, a very old medication, but it was only in 1982 that these three researchers were given the Nobel Prize for discovering how it worked. So imagine that there is a medication that actually works, and it takes another 100 years before somebody or several people can understand what the mechanism is. This is actually a little bit of an encouragement for the young scientists among you, that you may be able to discover something that's already been there for a long time, but nobody was able to figure it out. But these three men, Bergström, Samuelson, and Vane, they were able to understand that acetylic salicylic acid and also all the NSAIDs, the NSAIDs, that they also can stop the inflammation by blocking the prostaglandins. It's not a very effective treatment, but it can help, and it's certainly also good for trivial sources of pain. Now, there was another discovery that was made in the middle of the 20th century, which is also celebrated with the Nobel Prize, and that was the Nobel Prize in 1950 to Kendall, Rakestein, and Hensch, because they discovered cortisol, or dihydrocorticosterone. And this is, of course, what is used very widely in medicine, the corticosteroids or glucocorticoids. And it turns out that they can be effective in very many inflammatory states. And interestingly, when they received the Nobel Prize, these three gentlemen received it specifically because it was so effective for rheumatoid arthritis. So even though today corticosteroids are used for asthma and for bowel disease and for the skin and in instances of severe brain injury, there are many, many uses in medicine, but the Nobel Prize, the original discovery, was for rheumatoid arthritis. Now, there was a brief period when people were very, very excited about this because they thought it was the cure for rheumatoid arthritis. But to illustrate the problem, I have another French painter that I would like to introduce to you. He is not quite as famous as Renoir, but he was also very much respected. He lived a little bit later in the post-impressionist era, and he painted these beautiful works with very bright colors, especially blues, and also sunny and happy. And this is another example, an interior with open window. And as I said, he is not as famous as Renoir, but the art lovers, of course, know him. It was Raoul Dufy, and he lived in the first half of the 20th century. And he too suffered from rheumatoid arthritis. And his rheumatoid arthritis was, by the accounts that we have, a milder form, not as severe as that of Renoir, but he did have the pain, he did have the stiffness, it did prevent him from doing the things he wanted to do. And he was among the first patients who were treated with corticosteroids, with cortisone. And he actually has a painting that is called La Cortisone. And he witnessed that it was very effective for his arthritis. But now look at the year in which he died, 1953. It was a few years after the discovery of the corticosteroids, and he died of a bleeding stomach ulcer, or a stomach bleed. And we do not know why he had a stomach bleed. And it is possible that he would have had the stomach bleed no matter what. But it is also possible that he was one of the first who died from a serious complication of corticosteroid therapy, because we now know that long-term treatment with corticosteroids, especially at higher dosages, does tremendously increase the risk of stomach ulcers, stomach ulceration, and bleeding. So we may witness, in the case of Raoul Dufy, the combination of excellent efficacy and the real serious side effects. And this is, of course, where glucocorticoids are in the balance. We know how effective they are, but we also know how they have many side effects and risks, and especially with longer-term treatment. And that's why we do not generally recommend this as a treatment by itself for rheumatoid arthritis, but it may have many roles as an additional therapy. Now I'm going to make a jump in the history to the end of the 20th century, when you can say that at that point in time, it was possible to treat rheumatoid arthritis with conventional anti-rheumatic medications. Methotrexate has been established, sulfasalazine is used, gold salts are still being used, the injections, and sometimes these are combined. And then the corticosteroids can be used in addition, but not by themselves alone. And with these medications, some people did very well. That is certainly true. And then there were many patients who did okay, but not great. And unfortunately, there were also quite some patients who did terribly badly. And I started practicing rheumatology in the 1990s. And I remember that the truth was that if you went to an outpatient clinic for rheumatology and you were going to see a number of patients on that day, you knew there were going to be some whom you could not help. You, of course, you tried. Of course, you always thought, can I maybe try this way or do that? But in the actual fact, it was not always possible to help them. For many patients, the rheumatoid arthritis was a terrible chronic disease that they could not very well live with. And so it was a difficult situation for the patient and also for the doctor. But then things began to change. And the big changes that happened started around 1989, when several researchers, including Fionnuala Brennan and Mark Feldman, discovered that TNF, tumor necrosis factor, was a very central cytokine in the pathophysiology of rheumatoid arthritis. And so they then said that it might be possible to block TNF. And they had a little bit of luck because there were medications that had been developed to block TNF by companies that were not interested in rheumatoid arthritis at all. The companies were interested in sepsis, and TNF plays a role in sepsis. So that was the reason they had developed these medications. But then it gave an opportunity to clinical researchers in rheumatology to start testing the medications for the treatment of rheumatoid arthritis. And the rest, as you know, is history, because within a few years, there were the first reports of patients with rheumatoid arthritis who were treated with anti-TNF monoclonal antibodies, the same monoclonal antibodies that later were called infliximab. And the results were very impressive, and they were published. And then, of course, it started a whole series of studies that all confirmed that TNF antagonism is a very effective novel approach. In those days, it was novel for rheumatoid arthritis. So before I continue talking about that, I want to make a little side step to another development that took place during the same time. But let me emphasize that the TNF story, it went from discovery to the clinic in only a few years' time. And this story is different. This is a story of the tyrosine kinases. And tyrosine kinases is a large family of enzymes that we all have in our cells. And every cell of our body has tyrosine kinases, and they are very important for all kinds of processes that sustain life. And the discovery that led to this elucidation was made in small children who had terrible infections. They had an immune deficiency. And researchers at the National Institutes of Health, led by John Shea, could not quite understand why they had an immune deficiency, because they did have B lymphocytes and gamma globulin, so they did not have a gamma globulinemia. They did have T lymphocytes, so they did not have the Georgi syndrome. They did produce interferon gamma, so they did not have chronic granulomatous disease, but they still had all these infections. What was wrong? And the researchers discovered that the problem in these children was that the signal that the cell received and that was supposed to activate the cell could not activate the cell because a critical enzyme was missing. And that enzyme was a Janus kinase. It was one of the tyrosine kinases. And this spawned a large development of all kinds of discoveries at the basic science level about how things work intracellularly. And the end result of it is that it was possible to establish a critical role for JAK enzymes in rheumatoid arthritis. And then we did a trial, but look, now it's 2012. So this took 20 years before we did this trial with the JAK inhibitor tofacitinib. And it actually showed it was very effective. And this particular trial, which I was involved in, actually also showed that it was at least as effective as anti-TNF, maybe even more effective. So JAK inhibition came to be a really clear other way of treating rheumatoid arthritis. But this also illustrates that sometimes, due to maybe also a little bit of chance, it can take 3 years or it can take 20 years for a discovery to come to the clinic. More recently, we actually did a study with another JAK inhibitor, upadacitinib, and this study that you see here shows that if you use it as a first-line treatment, upadacitinib is very effective and more effective than methotrexate. But I'll get back to that story a little bit later. So now this has mostly been about the history, but so where are we today with treating rheumatoid arthritis? Well, first of all, as you know, we can now use the conventional medications, but we can also use 9 different biologics. And these biologicals, they have 5 different mechanisms of action. And these 9 biologicals also now exist in several similar molecules, biosimilar. So it's actually the number of molecules is increasing, but there are 9 different compounds. And on top of that, there are 4 different JAK inhibitors. At least that's the way it is in Europe, where Upadacitinib has been approved, and also filgotinib. I do not know what the situation is in Chile. In the United States, filgotinib is not approved. But worldwide, there can be differences. But this is what is in the whole picture available. So a lot of choice. And so what is the result then? Well, if you now look at the treatment of rheumatoid arthritis in 2021, you can say, well, many patients are doing very well. And that is great. And we are very happy. The patients are happy, and the doctors, the nurses, we are happy that it's going so well with many of them. But not all. And I want to bring your attention to a paper that was published just in January by George Nudge in Budapest. And he and his colleagues described for EULAR, for the European organization, a group of patients that you can call difficult to treat rheumatoid arthritis. And they proposed a definition. They said this is a group of patients that you can characterize by they have failed at least 2 different biologicals or synthetic DMARDs with different mechanisms of action. They are active, their disease is active, they have swollen joints, and they have ultrasound evidence for synovitis and a high sedimentation rate. And it's a real problem according to the patient or the doctor. So this is a subset of patients who you can call difficult to treat, RA, and it turns out that it can be as much as 15 to 20% of all the patients. So it's not trivial. Now, a second limitation, of course, is that all these treatments, all these biologicals, the JAK inhibitors, and also, of course, the conventional DMARDs, are in fact lifelong treatments. We do not really have the perspective of stopping, and the patients know that. And so that's not something that most patients are very happy about. Most of us, I think, would agree that it would be nice not to have to take a medication your whole life. Then, of course, there are the side effects and the risks. And these are not great, and we are happy that biologicals and JAK inhibitors are generally safe, but we always have to be aware of these. And there are the high costs of these medications. So the question is, how can we do better? What can be improved further? And there are really 2 ways. One is that you could hope for better medications, but I have to tell you that there are not so many more medications in development. It is not as though there are many clinical pharmacology programs to develop additional new medications for rheumatoid arthritis. But there might be ways to use the existing medications in better ways. And that's where I think we are seeing some really exciting new developments in rheumatoid arthritis. So when I speak about how to use the medications, then of course, I'm talking really about the treatment strategy. What is the approach? How do you choose for each individual patient what to give them? And the most commonly used strategy is really the step-up therapy strategy. And what I mean with that is, for example, what is suggested by EULAR in the EULAR recommendations, the European recommendations for the treatment with the treatment of rheumatoid arthritis. What they say is, basically, they say you have to start with a conventional DMARD, usually methotrexate, unless there is a specific contraindication, and you try that. And then if that doesn't work, then you increase the treatment intensity in a stepwise manner. So you may add something, sometimes you switch. And there is the treat to target principle, which is that you have to check every 3 months or every 6 months, but certainly in the beginning, every 3 months. And if it's not going well, if it's not going in the right direction, at least, then you do have to make a change. So treating to target tells you that you really should look at the patient carefully and also change things. But mostly the plan is really a step up, that you go from a first step, a second, and third. And that is what usually happens, is that you start with methotrexate, you maybe try another DMARD, conventional DMARD, and then you add a biologic, or nowadays sometimes a JAK inhibitor. So that is the usual sequence. But an interesting thing is that most of the biologicals are in fact approved by the authorities as first-line treatment. So if you look at the European Medicines Agency or the Food and Drug Administration in the United States, and perhaps also at your authority in Chile, they say that it is actually allowed to use the biologicals as the first treatment. Of course, the insurer may not agree with that. So in Holland, in the Netherlands, where I work, the insurance companies have said, well, we don't care if it's allowed by the EMA, but we're not going to pay for it. So that's another story. But the EMA, which makes only the scientific determination, says that it is perfectly okay to use the biologicals as first-line treatment. Now, I already showed you that for one of the JAK inhibitors, at least for the upadacitinib, it was shown very clearly that if you use it as the first-line treatment, which is not approved for upadacitinib, but in the trial it was done, then you see an outstanding result with more than half of the patients achieving an ACR 50 after 12 weeks, and also almost half of the patients achieving a remission according to DOS by 24 weeks. And that is more than double what you get with methotrexate. So it clearly shows that if you have to choose one drug to start with, then starting with the JAK inhibitor is much better than starting with methotrexate. Now, this study by itself has not at all resulted in a change in recommendations. Why not? Well, because most authorities would say that it's not fair to compare with just methotrexate, because all the clinicians know that when you start methotrexate, in practice, you add corticosteroids. You give the patients some injections with corticosteroids, or you give them oral corticosteroids or intramuscular, but you do something because everybody knows that methotrexate takes a long time to work. So this comparison is scientifically interesting. From a practical point of view, it's not so relevant. But we can discuss this if it is or isn't important. Now, there is another possibility, and I believe my slides are okay. I had to check the slides. There is another possibility, which is that we could start with a more intensive treatment and then step down. So I told you about step-up therapy, but another strategy would be that you would maybe start with stronger treatments first and then try to bring it down. And that sounds like a very modern idea, but in fact, it was already published in 1994 by a colleague from Amsterdam, Professor Maarten Boers. And what he and his colleagues did was they treated patients with rheumatoid arthritis from the start with 3 drugs: methotrexate, sulfasalazine, and also corticosteroids. And then after the patient had achieved a good state, then they would bring it down, and they would continue for the longer term with just sulfasalazine. And that actually worked out reasonably well. And in fact, a later analysis done by Robert Landewey, who is also still in Amsterdam, showed that this approach, which was called COBRA, combination therapy for rheumatoid arthritis, actually gives better results than just sulfasalazine alone, which is shown on the left lower side. And it is, of course, quite believable because sulfasalazine is not considered a very strong medication. A later study by Debbie Den Uyl, also in Amsterdam, showed that the original COBRA trial, it used 60 milligrams of prednisone. That's a lot. And she did the same thing with 20 milligrams of prednisone. And then it was actually almost the same result. So the COBRA light approach seems to be actually also very effective and with less steroids. So this is an example of an older study that shows that you can try to start with a combination and then continue with just one medication. And this you could also call induction maintenance. So this is a strategy concept that comes from oncology. Induction maintenance means during a limited period of time, you give a very intense treatment. You give a very strong, powerful treatment, because that gives you the possibility of bringing the disease completely under control. And then once you have established that, then you can maintain the control with simpler means, with a simpler medication, a safer medication, perhaps a less expensive medication. Now, in rheumatology, we actually do have examples of induction maintenance. The treatment of lupus nephritis that was pioneered at the NIH consisted of cyclophosphamide infusions every month and then followed by every 3 months. The much more customary Euro-lupus schedule starts with cyclophosphamide for 3 months and then azathioprine as maintenance. ANCA vasculitis is often treated in this way by an initial treatment period of stronger medications and then something to maintain it that is less intense. And as I mentioned, in rheumatoid arthritis, the COBRA idea and the COBRA light variation are certainly still also good possibilities, and similar attempts have been made in many different ways. So induction maintenance is something that we actually do as rheumatologists. And the question is, would that be the best way to do it? Now, I want to get back to what I mentioned, which is that biologics are actually approved as first-line treatment for rheumatoid arthritis. So why do we not do that? Why doesn't EULAR say that we should use biologics as first-line treatment? Why doesn't the American College of Rheumatology say that, or the Chilean Rheumatology Authority? I don't know about in your country, but I do know why EULAR doesn't say it. And the reason is that there are 4 reasons not to say that. First of all, if you would give every patient a biological, then you would overtreat some patients, because we know from experience and from studies that with just methotrexate, many patients actually do fine. So we would not want to give too much medication to people in general, and in this case, that would be clearly the case for some people. Now, usually anti-TNFs have to be combined with methotrexate, so it's 2 drugs instead of 1. And so you also get more side effects or more risks. So, and that's very simple. And so that is also a reason not to do that. But I do think that if it all comes down to it, the cost issue is a very big issue. I think that this has played a very big role for EULAR, maybe also for the ACR, to say that they do not recommend the use of biologics as first-line therapy because it would cost a lot of money. And that by itself is not a very strong argument, because in medicine, we do not like to think that way. Of course, it's also a reality. It's also a fact of life. But this is something that we have to be careful with. And then the 4th argument is a little bit more complicated, because there are some studies that show that if you take a group of patients and you treat them with the usual step up, methotrexate first, and then maybe leflunomide, and then maybe an anti-TNF. And there's another group of patients, and you start with the anti-TNF right away. Now, that second group, they may do better for a while, but after 2 or 3 years of this, it doesn't make a difference anymore. So you could say that the more conservative approach, the approach with conventional DMARDs, in the long run, it gives the same result. That's a true argument. I'm sure that's true, but I don't think that's a very good argument towards the patient to say, well, just wait for 3 years and you'll be at the same point. I think for the patient, it would be very good to know that they can get very much better very quickly. So this 4th argument is a little bit plus minus. I don't think it's a very strong argument, but it is true and it is sometimes mentioned. So this is an example of an induction maintenance study in rheumatoid arthritis that I was involved in many years ago using a biologic. It was done with adalimumab. And the treatment that was given to the patients, there were 3 arms, and I apologize for the slide being a little bit blurry, but the 3 arguments, the 3 arms were, one arm received methotrexate as monotherapy, one arm received adalimumab as adalimumab with methotrexate. There were no patients who received adalimumab monotherapy. It was methotrexate or adalimumab as a combination with methotrexate. But then, importantly, of those patients, half of them continued with both, and the other half, after 6 months, they stopped again. And then you can see that these 3 groups that are analyzed here are only the patients who responded initially. So that's why they all start at 100%. Because this graph is only for the patients who responded initially. But if you take those patients who responded initially, then you can see that it makes absolutely no difference if you continue the anti-TNF or that you stop again with the anti-TNF after half a year. So this is an interesting finding. It is perhaps not what the makers of adalimumab wanted, because it tells us that you can actually stop their drug. So maybe they were not so happy, but we thought it was scientifically very interesting, and the Lancet really also liked it and published it. But here's the thing, that you can say that this is something that proves that you can do this, that you can give patients methotrexate plus anti-TNF to start with, and once the patient has responded, you can stop the anti-TNF. But of course, the question is there any reason that you would want to do that? Is there an advantage to doing it? And there may be. And from other studies, we can see that there may be an advantage. This is the PRIZE study, which was published by Paul Emery and colleagues. I was not myself involved in it, but it was a very elegant study. The patients were first given methotrexate plus etanercept. And then they were allowed to continue for a year with that. And if they achieved a remission, then they went on to the next part of the study, and that's what's shown here. So this part of the study starts with a group of patients who have been given methotrexate plus etanercept, open label, and they have responded, they have achieved a remission. And now these patients are randomized. Some patients continue with methotrexate plus etanercept, but the etanercept is actually the half dose, 25 milligram once a week. So they already make it less, but they continue with both medications. That's the top line. Then there are patients who continue with just methotrexate, but not etanercept. That's the middle line. And there are some patients who are stopping completely. They continue with no drugs at all for their rheumatoid arthritis. And that's the bottom line. And so you can clearly see the difference, and you can say that it's obviously the best is to continue with both. But if you continue with just methotrexate, there are actually quite some patients who also do okay. More than half will do okay. And there are even patients, and this is quite surprising, there are even patients who they stop everything and they still continue to do okay. And it's almost a third, or even maybe more than a third, depending where you look. So this is very surprising. Some patients do well without treatment. I do think it's true. We probably underestimate the degree to which nature can also heal. But that's a separate story. What I mostly want to emphasize is that you can here see the difference between the three groups for the first year of this randomized part of the trial. And I have to, by the way, also tell you that if a patient started doing worse, they were given new treatment. So this looks like it was unfair to the patients because many of them started doing worse. But if they started doing worse, then they got medication again, but the graph is then extrapolated. Anyway, there was one more part to this study, which was very interesting. And that is what happened at the vertical dotted line after almost 40 weeks. Because at that point in time, if the patients were still in remission, the treatments were all stopped for all patients. Now, when you do that, you can expect the patients to start doing worse. And you can see how the top line, it drops down because those patients were taking methotrexate and they were taking etanercept. And then these two were stopped. And of course, many of them started doing worse. And again, they were then allowed to go back on the treatment. But not all of them did worse. And some patients actually continued to do well without treatment. Of the ones who were on methotrexate, if they stopped the methotrexate, some of them started doing worse, but others continued to do fine. And also those patients who were already on no treatment, some of them continued to do well. And so this is, again, that slightly mysterious things that sometimes patients with rheumatoid arthritis will be able to do well without treatment. But the most interesting part is way at the end, to the right on the slide. You can see that the numbers are different. For those patients who were given methotrexate plus etanercept for a full year and then continued at the lower dosage for almost 9 months, for those patients, in the end, there are more who do well without treatment than for those who were given the methotrexate plus etanercept and then stopped completely already after a year. So this suggests that if you have a longer period of time with intensive treatment, there's a better chance of being able to do well without treatment. It's a very intriguing finding. It's not so easy to translate this into practice, but it could be a proof of principle that a treatment that is very effective in the early phase, if you continue with it and maintain the patient on it for a longer time, they can then be okay without treatment at some point in the future. But how to examine this, how to investigate this further? Let me show you another example of a study that suggests that this may be true. The study is a little different. It's done with certolizumab, also, of course, an anti-TNF medication. And in the first year of this trial, the patients were given either methotrexate, the blue line, or methotrexate plus certolizumab, the orange colored line. And you can clearly see that the combination treatment is more effective than methotrexate, which is what you would expect, and which we've already discussed, that the combination is a little bit better and it is statistically significant. And you can say it's also clinically quite relevant. But what was done in this trial, and which was very novel at the time, was that at 52 weeks, the certolizumab was stopped, and the patients continued with just methotrexate. Now, if you stop certolizumab, some patients will do worse, and you can see how the orange line, it starts going down after the 52-week point when the certolizumab is stopped. But the patients who continue to do well are then at a stable phase. And the interesting thing is that it's still more than the patients who are doing well with just methotrexate from the beginning. So even at the end of 2 years, there is still a difference between the groups, even though for the last year, they have been treated exactly the same way. So these groups of patients are on the same treatment, but half of them are doing better. And the reason is what happened in the past. The reason is how they were treated a long time ago. So that initial treatment has a carryover effect, and it makes the disease easier to treat later on. That could be very important. And I was wondering if this was true across all of the different studies that have been done. And I asked one of my PhD students, Sharzad Emamikia at the Karolinska Institute, if she could look at that as a meta-analysis. So she looked up all the trials that have investigated this question. And a meta-analysis combines all these data into one, and that's the black diamond that you can see. And if the black diamond is shifted to the right, then it means that the treatment is more effective. And so you can clearly see that the treatment with methotrexate plus anti-TNF, that's the black diamond in the middle, it is a little bit to the right. So obviously methotrexate plus anti-TNF is more effective than just methotrexate alone. But even after you stop the anti-TNF, a year later or 6 months later, it's still more effective. That's the diamond on the bottom, which is also to the right. So there is still a residual effect, sometimes a year later. And that is an important message, that what we do early on in the treatment of rheumatoid arthritis can have such a long-lasting effect for the patient. And that brings me to the final part of my talk, which is about the North Star trial. North Star trial is a clinical trial that we set up with investigators in the Nordic countries. Nordic is Scandinavia, you know, Norway, Sweden, Denmark, also Finland, Iceland, and now that I'm in Amsterdam, it's also in the Netherlands. And the North Star trial was an investigator-initiated trial in 800 patients, very big, with newly diagnosed rheumatoid arthritis. And these patients were randomized, so they received one of 4 different treatments as the first treatment of their rheumatoid arthritis. Some patients received the conventional therapy, but we called it aggressive or active conventional therapy. And I'll tell you in a moment what it is, but it is basically methotrexate, but not only methotrexate. There was also corticosteroids added to it, and you could choose if you wanted to give prednisone orally or if you wanted to give multiple joint injections. There were different possibilities, but it was an active conventional approach. And then there were 3 other arms, and they all received biologicals, but with different mechanisms of action. There was one group that received methotrexate plus certolizumab, anti-TNF. One group received methotrexate plus abatacept, which is a T-cell co-stimulation modulator. And one group received methotrexate plus tocilizumab, anti-IL-6. And we had decided that we would look after 24 weeks at the primary outcome. And so the first question is, which of these 4 treatments is the most effective? And then there were some additional questions later on. But first, the primary outcome, of course. This is what the primary outcome shows. If you give the patient an active conventional therapy, then a little bit more than 40%, 42% achieves remission. And we define the remission as the CDAI remission. CDAI is the Clinical Disease Activity Index. It's based only on clinical parameters, swollen joints, standard joints, physician and patient's assessment. And so there's no artifact from blocking CRP. And this was achieved by more than 40%. And I have to be honest with you, that was more than we had expected, more than we had anticipated. When we designed the trial, we thought it would be 20, 25%. But it was much more, which is very good news for the patient. This turns out to be a very positive message from the trial, that the regular conventional therapy, if you add to the methotrexate also corticosteroids, you can actually achieve this kind of remission in very many patients. I should add that the CDAI remission is a very tough remission criterion. It is a remission that is comparable to the SDI remission, which is comparable to the ACR-Euler Boolean remission. And so it's very strict. So if the patient has this remission, they are really doing very, very well indeed. Of course, many more patients had a low disease activity or other response. So the conventional therapy worked well in 42% of cases. For the patients who received anti-TNF, it was a bit higher, 47%. For the patients who received abatacept, it was the highest, 52%. And for tocilizumab, it was again about 42%. So it seemed that two of the biologicals were more effective than the conventional therapy, but not by much. And you could discuss if it was really relevant that they were higher, if that is important, if that has clinical meaning, but those are the numbers. You can ask about statistics. For the statistics, we went to a statistician, and he did an analysis which was much more complicated in terms of the numbers, and it gave these graphs, which are actually also based on characteristics of patients that were modeled. So these are model values, and it looks a little bit different. You can see that the conventional therapy is blue, so it goes up nicely, and it ends up at a bit more than 40%. The anti-IL-6 is not better than the conventional therapy. That was a little bit of a surprise to us, but that's what it showed. And the anti-TNF and the abatacept arms were both better than the conventional treatment. And the statistical significance was not achieved by these arms in this analysis. So we cannot claim that the biologicals are better. We can say that they're numerically a little bit better. And for abatacept, it was on the border of clinical significance, depending a little bit on how you did it. What you could ask is if there is a situation where you can say that the conventional therapy is as good as the biological. That's the non-inferiority test, and that's done in this way. It's a different plot. You have to analyze it in a different way. And I don't think it's worth it to go into a lot of detail about it, but the bottom line is that we can now say that conventional therapy is not inferior to tocilizumab. It's also not inferior to anti-TNF. It could still be inferior to abatacept because there the difference was a little bit bigger. But all these results suggest the overall picture that, yes, you can treat with biologicals from the beginning, and you may get slightly better numerical values, but it's not so convincing. And we do not think that the North Star trial suggests that you should use biologicals as first line based on these results. So for now, we think that actually the recommendation to start with methotrexate and conventional therapies is a very good recommendation. But I do have to warn you that we're going to see more results coming from the North Star trial. We are going to look at the results after week 48. And by that point in time, the patients will have stopped their prednisolone. So if they were on prednisolone, they could have been on low dose for 24 weeks. But by 48 weeks, it will be stopped. That could change the way the numbers look in the conventional therapy group. We will also start looking at the radiographic results. Maybe there's a difference in how much damage develops during the first 6 or 12 months of the disease, depending on what treatment the patients are given. We're also going to look at patients who have been in remission for 24 weeks because they are allowed to taper the biological or maybe even stop the biological. Are they going to flare, or are we going to see what we saw in the other studies, that it may be possible to continue without treatment? And maybe in some patients, will they be able to even stop the methotrexate as well? So these are all questions that can be asked and that we will be able to answer in the North Star trial in the coming months and years. So we're excited about this trial as a source for much information about the treatment of early rheumatoid arthritis. And that brings me to the final part, which is the future really for rheumatoid arthritis treatment. To treat rheumatoid arthritis even more effectively, I think we need to look at how the patient even gets to have rheumatoid arthritis. Because we now know from many researchers' work, but especially the late and much beloved Enka Katrina, who passed away earlier this year, that there is a preclinical phase when the patient already has the autoimmunity, and they may not have a lot of complaints, but they may have a little bit of symptoms, and then they develop the disease, and this may take months or even years. And the question is, can we maybe intervene even earlier than when the disease has started? The thought is that much of this iceberg may be under the surface of the water. Much of it is happening without us actually seeing it. And yet it is possible to predict that people may develop rheumatoid arthritis. And this was done by Lotte van der Stad in Amsterdam, who showed that by using some clinical characteristics and by using some measurements, you can actually predict fairly accurately that some people have a high risk of developing rheumatoid arthritis, sometimes as high as 80%. Now, you can ask the ethical question, why do you want to predict rheumatoid arthritis if you cannot do anything about it? But we do think that it is something that people do want to know, that they want to be informed. And there are some suggestions that you could change your lifestyle to decrease your risk. Stopping smoking, certainly. Maybe also more attention to diet. There is one study suggesting that going to more plant-based food actually decreases your risk. So that's possible. And of course, we're very interested in maybe treating preventatively. And in Amsterdam, colleagues of mine did this study called the Prairie Trial, where they investigated if it was possible to prevent rheumatoid arthritis by B-cell depletion. And this was based on 82 patients who had some arthralgia, so they were not asymptomatic, they had some pain, and they did have a slightly elevated CRP, and they had ACPA and rheumatoid factor. So clearly their risk had to be seen as high. And they were randomized to receive 1,000 milligram of rituximab or placebo, and the development of clinical arthritis was the primary endpoint. And this study showed that B-cell depletion did not prevent rheumatoid arthritis. At the end of the 4 years of follow-up, equally many patients had developed rheumatoid arthritis in both groups. It was about 40%. So that was a bit disappointing. And the only thing that actually changes the assessment a little bit is that the patients who had received rituximab developed rheumatoid arthritis later, on average, almost half a year later than those who received placebo. So there seemed to be a delay, but no prevention. And this has also been seen for other attempts to treat preclinical rheumatoid arthritis. These are just some additional studies that were done in the Prairie Trial to show that the B-cell biomarkers were downregulated effectively, so the treatment worked at the immunology level, but as I said, the clinical level was not so clear. So we are still interested in trying to find better ways of treating rheumatoid arthritis, including very early treatment, and also trying to maybe in the future prevent rheumatoid arthritis by intervening at the time when the person is at high risk of developing the disease. But for now, I want to go back to where I started, which is saying that compared to how it was 20 years ago or even longer, we have gotten so much better at treating rheumatoid arthritis. So many more of our patients are doing well that we can be very happy with the progress that we have been making. And I do think there's also a reason to be optimistic that we will be getting better all the time. Thank you very much.